Good morning. My name is Ellie Zhou. I'm the Ocular Pathology Fellow, and the title of my talk is Not My Cup of Tea. My discussants are Dr. Dubovi and Dr. Uchiyama. I have no financial disclosures. So we have a 77-year-old male who presented to an outside clinic with decreased vision in the left eye for 2 months with associated floaters in the left eye, no flashes, no distortion of vision, and no pain. Past ocular history was insignificant. So past medical history, hypertension, prediabetes, heart disease, and motor neuron disease. And I'm withholding an additional past medical history. Family history was non-contributory, and he's had several past surgeries, and he's on medications for his systemic conditions, and he's allergic to shellfish. And on exam, his visual acuity was 20/30 in the right eye and 20/50 in the left. Pupils were equal with no APD. Pressures were within normal limits. Confrontation of visual fields and extraocular eye movements were normal. And can I have one of the residents please describe the slit lamp exam findings?
So we have external photo here of the left eye. Lids and lashes look relatively normal. Conjure's uninjected. Cornea is clear. AC appears deep. Looking at the magnified view, I don't see signs of cell or flare in the AC. Lens is relatively clear. In the vitreous, it looks like there's a little bit of, I don't know, maybe some vitritis. And inferiorly in that photo, I can't tell if there's something that's more condensed.
Right, exactly. Some vitritis in the left eye, and right eye was normal. And then the fundus.
This is a fundus photo of the right eye. Clear view in. Optic nerve looks normal. Slight vascular attenuation. The macula appears to have just some RPE modeling. And in the periphery, again, there's some pigmentary changes in the far periphery, but no hemorrhage, no exudation.
Right, exactly.
And then a fundus photo of the left eye. View in is mostly clear, although there's some areas that do look obscured. The disc looks grossly normal, but it's hard to appreciate fine detail. Vascular pattern is normal, though, with a little attenuation. There's areas of, looks like RPE hyperplasia or hyperpigmentation seen in the macula and in the mid-periphery.
Exactly. And then FA.
So we have an FA. This is looking first at the right eye. There's some hyperfluorescence around the disc, but there's no obvious areas of leakage, no vascular leakage. Even in the later frames, we don't see any.
Right, exactly. And then the other eye.
And this is in the left eye. Later frames does look to be slightly obscured. The disc again looks to have some areas of hyperfluorescence, but looking further in the frames, we don't see any signs of vascular leakage.
Exactly. All right, so your differential diagnosis.
So I have a 77-year-old male with months of vision loss in the left eye. He's got an intriguing past medical history that we don't know, and with vitritis. So, I mean, you could be thinking of infectious causes, TB, syphilis, any other kind of fungal etiology seems less likely in this guy. It could be something that's like a systemic problem, like you could think about intraocular lymphoma, you could think about sarcoid, you could think about some of the uveitis like VKH, although we didn't have anything to suggest that. We don't know if he's had surgery. It could be sympathetic ophthalmia.
So I think you hit upon most of those. So my differentials were infectious and non-infectious and masquerade syndromes like intraocular lymphoma or metastasis from carcinomas or paraneoplastic syndromes, or it can also be idiopathic. So what additional information would you like to know about this patient?
That past medical history is intriguing.
Right, exactly. So I withheld a piece of past medical history. So actually on skin exam, this patient had erythematous ulcerated lesions that look infected on the abdomen. as well as multiple patches and plaques in different areas throughout the body. So he had a previous skin biopsy that showed a superficial and deep lymphoid infiltrate composed of atypical lymphoid cells that show epidermal tropism. And on immunohistochemistry, the infiltrate is composed mostly of CD3 positive T cells with a subset of CD20 positive B cells. And the cells are also positive for pan T cell marker CD5 and CD7. And then there's a positive CD4 and positive CD8, and the ratio is about 2:1. And it was negative for CD30. And he also had a T cell rearrangement study that showed a monoclonal T cell population. So this diagnosis with the clinical findings is consistent with cutaneous T cell lymphoma or mycosis fungoides. So mycosis fungoides, a little bit of background. Means mushroom-like fungal disease. It's a primary cutaneous T cell lymphoma, first described in 1806 by French dermatologist Alibert. He observed these mushroom-like lesions on the patient, but he also realized that they were not caused by fungus. And it's characterized by epidermal tropic T helper lymphocytes or CD4 positive lymphocytes. And clinical course is slow progression, usually over years or decades, and it presents with a stepwise evolution of patches, plaques, and tumors. And incidence is 6 per million, and it's the most common primary cutaneous lymphoma affecting adults in the 5th to 6th decades with a male to female ratio of 2:1. And on histopathologic finding, you can see epidermal tropism like we saw in our patient, and small to medium-sized lymphocytes with cerebriform nuclear contours and hyperchromatic nuclei. And the immunophenotype I already mentioned earlier, mostly CD4 positive and CD8 negative with loss of expression of T cell marker CD7. So what would you do next given the history of mycosis fungoides?
Yeah, I'm concerned that he has intraocular spread of this, so he could maybe a diagnostic vitrectomy to get some cells.
Right, exactly. So the patient undergoes a vitreous biopsy, and the vitreous biopsy shows two populations of cells, one small cell population, and the other is a large cell population. And some of these cells show irregular nuclear contour with large nucleoli. And on immunohistochemistry, these cells are mostly CD3 positive, and they're also positive for T cell marker CD2 and CD7. And then here, the CD4 to CD8 ratio looks like there's more CD8 cells than CD4, and then there's aberrant expression of CD19. On flow cytometry, it basically showed the same findings, and they also did T cell PCR that showed a monoclonal cell population. So these findings are consistent with a T cell lymphoma. However, our patient's vitreous biopsy showed more CD8 positive T cells, which is not typical for mycosis fungoides, as they're usually typically positive for CD4. But looking back at the patient's previous skin biopsy in 2016, it was more typical for mycosis fungoides with a CD4 to CD8 of 8:1. And then as disease progressed, he had a decreased ratio of CD4 to CD8, and eventually in the vitreous, he had more CD8 positive cells. So this has been reported before in a patient previously with a similar findings with mostly CD8 positive T cells in the vitreous. And they reported that CD8 positivity and immunotypic shift in skin biopsies seem to be associated with more aggressive disease, which is probably what happened in our patient because he was only diagnosed with mycosis fungoides about 1.5 years ago. So final diagnosis was cutaneous T cell lymphoma with intraocular involvement by T cell lymphoma. And because of his intraocular involvement, he is now stage 4B with mycosis fungoides. So my objectives, I'll go over some of the different types of intraocular lymphomas and then show a few cases of mycosis fungoides with ocular involvement. So primary intraocular or vitreoretinal lymphoma is a spectrum of primary CNS lymphoma. It's typically a diffuse large B-cell lymphoma, typically presenting bilaterally with a mean age of 60. The hallmark findings of primary intraocular lymphoma is vitreous cells and sub-RPE infiltrates. And approximately 1/3 of patients will also have CNS disease or will eventually develop CNS disease. And secondary intraocular lymphoma represents metastasis to the eye. The age is variable and it can be unilateral or bilateral and typically affects the uveal tract with a discrete mass-like infiltration. And systemic involvement is usually known. So this is a patient that presented to Bascom Palmer that had a history of breast lymphoma, which metastasized to the choroid. And interestingly, systemic T-cell lymphoma with secondary involvement of intraocular structures shares similar findings as primary intraocular lymphoma. So vitreoretinal involvement without uveal involvement is typical. And then lastly, primary uveal lymphoma is generally a low-grade B-cell extranodal marginal zone lymphoma, usually unilateral and commonly affects men in the 5th to 7th decade, and is characterized by a diffuse multifocal creamy yellow choroidal infiltrate, as seen here and here as well. This is pretty typical of primary uveal lymphoma. So just a few words about ocular findings of mycosis fungoides. Stenson et al. Reported the largest series of mycosis fungoides with ocular involvement. They found 11 patients of 30 patients had mycosis fungoides with ocular findings. And they found that the most common finding was lid tumors. And they also found caruncle tumors and keratitis, and 3 cases of optic atrophy and just 1 case of uveitis. And other cases have reported different findings, including bilateral disc swelling, white subretinal lesions, and vitritis. And this patient unfortunately died 2 months after presentation. And then vitritis can also be an initial presentation of recurrent mycosis fungoides. So this patient didn't have any more skin lesions, but he presented with vitritis, both eyes, and he died of CNS metastasis 5 months later. And rarely it can also present with hypopyon. In this patient, there's bilateral hypopyon. This patient was actually treated with external beam radiation and with complete resolution of the hypopyon on day 10 of therapy. So these patients respond pretty well to external beam radiation. And then last case I'm going to show is a case of anterior uveitis with subretinal infiltrate. And this patient was treated with intravitreal methotrexate. And after 6 treatments of over 82 days, the infiltrate resolved. So just treatment I already touched upon, intravitreal chemotherapy with methotrexate, external beam radiotherapy, or systemic chemotherapy in cases of CNS involvement or systemic disease. And prognosis is typically poor for patients with stage 4B mycosis fungoides, like in our patient, and with large cell transformation and tumor stage in the skin finding. So after the diagnosis was made, the patient was referred to Bascom Palmer Oncology for management. Patient was also referred to Sylvester to see a general oncologist. When he presented to Bascom Palmer, he had bilateral vitritis. So when Dr. Harbour saw this patient, he was thinking he probably needs external beam radiotherapy after he sees the general oncologist. And summary, mycosis fungoides with vitreous involvement is rare. Variable clinical presentation including vitritis, panuveitis, chorioretinal lesions, optic nerve infiltration, anterior chamber involvement can be seen. Patients generally respond well to radiation or intravitreal methotrexate. However, prognosis is still poor after intraocular involvement. So a few questions. What are the typical findings of primary intraocular lymphoma? Since I don't have the audience response system, it is subretinal, sub-RPE, and vitreous cells, so D, B, and C. And then what are the findings of secondary intraocular lymphoma? It's typically a B-cell lymphoma with uveal tract involvement and can present as a discrete mass. And this is my abstract and references. And I want to thank Dr. Uchiyama and Dr. Dubovi, Dr. Harbour, Dr. Vega, and Dr. Lin, Dr. Monsalve for their help.